Some of us feel called to careers that have meaning, work that lets us make the world kinder, safer, and healthier. Social work is that kind of calling. Social workers are top providers of mental health care in the United States, and the field has a wide variety of rewarding career paths. You might work in a school, a center that specializes in recovery from addiction, a government agency that secures the wellness of children, a nonprofit organization, or a hospital. Indiana University's School of Social Work is the highest ranked and largest in the state. For over 100 years, we have provided innovative instruction to students who are passionate about helping others. You can pursue a degree no matter where you live in Indiana. Social work programs are offered on 7 IU campuses and online. You'll learn from caring faculty and gain hands-on experience through internships, whether you are seeking your bachelor's or master's in social work. If you are interested in a career in research, we also offer Indiana's only PhD program. So if you are ready to explore a career that's rewarding, challenging, and never boring, the IU School of Social Work is ready to help you change the world.
Good morning, you all. Today we come here to present Black and Indigenous people of color, BIPOC mental health matters, disparity to parity. And I am Marcus Brown. It is a pleasure to be here with you today.
Hello, my name is Kendra Johnson, and I am also glad to be here with you today.
Hi, I am Monique Johnson. In this workshop, you will examine the social problem of the unmet needs of Black and Indigenous people of color, how the conditions of our housing, employment, and healthcare system affect health outcomes, the impact of mental health in Indiana, and discuss recommendations and implications. Before you start this presentation, you will need to know your position. What is your position? Positionality refers to the differences in social position and power shape identities and access in society. All parts of our identities are shaped by socially constructed positions and memberships to which we belong. Positionality is the social and political context that creates your identity in terms of race, class, gender, sexuality, ability status, and among other characteristics. Positionality also describes how your identity influences and potentially biases our understanding of the outlook of the world. This means that depending on how you identify your membership to a particular group will dictate how you view various aspects of society. For example, if I have a learning disability, I may view others that identify with the same issues as me as hardworking because we have to try twice as hard to understand a concept. I may also see members of my group as determined because we continue to seek educational advancement even though our learning styles may not be accommodated. I also see those in my group as compliant because we have to assimilate to what the norm education style is in society. Those outside of my group may think that we are lazy because if we just worked harder, we can be cured. They may also think that we are stupid, but having a learning disability has nothing to do with my intelligence level. And lastly, they may think that learning disabilities are all the same, but there can be problems with reading, understanding math, writing, listening, speaking, or just paying attention. Not only do the groups that we identify with affect our perspectives, but also our experiences affect our social positions on how we perceive the world. It is important to always reflect about your positionality when you work with clients. As you go through this presentation, it is important for you to reflect on your position regarding mental health and your position regarding people of color. What are your beliefs about this topic? Kendra, do you have thoughts?
Yes, so from my experiences and just working in the field, there is not enough representation in mental health providers and educators. And I believe that experience matters and has to be taken into consideration. My motto is that therapists need therapists for routine emotional and mental self-care, and there is a lack of access for various reasons that we will discuss today in the BIPOC community. I also believe that societal trauma and oppressive institutions are a huge factor in a person of color's mental health in the US. Marcus, what are your beliefs about the topic?
I must say that I do believe that mental health is real, and I do believe that we have to address a person's mental health. I do believe that programs and services and what we view as evidence-based practices may be a one-size-fits-all model, and we cannot adapt that to individuals who come from various backgrounds. We have to figure out how can we tailor the needs of programs and services in order to meet the needs of BIPOC. I believe that this is an important topic for us to have because we have to realize that disparities exist in mental health care, and we have to find ways to address the mental health disparities among the BIPOC community. Monique, what are your beliefs about the topic?
Well, from my education and my own personal experiences, I do believe that having a mental health concern is normal and it can affect anyone. I believe that adequate sleep and other self-soothing activities is a major factor in taking care of yourself. I believe that there is a difference between someone who has a severe mental illness that affects the person's baseline functioning to where we would call that person as like not acting normal, or what society sometimes term as crazy, which is a derogatory word. I believe one of the biggest factors for a person of color's mental health in the US is societal trauma and the denial of access to their identity in order to fit within the dominant culture. As you watch this presentation, think about what are your beliefs about this topic. By the end of this presentation, you will have increased awareness and understanding of racial health disparities in mental health care among BIPOC individuals. You will be able to identify the differences and similarities among racial minorities, specifically African Americans and majority groups regarding mental health experiences, needs, and beliefs. You will also be provided recommendations to address the relationship between the BIPOC community's mental health needs and the influence of community contextual factors, social norms, and stressors of discrimination and racism.
Perfect. So let us start with the social problem. When we are attempting to address something like a societal problem or a problem within our agencies, our organizations, or within programs and services that we have at our agencies and organizations, we have to stop to think, well, what is the social problem? Is the condition that has a negative consequences for individuals who are marginalized. In this case, mental health is a huge social problem among BIPOC, which we will examine throughout this presentation. Overall, to give you an overall sense of mental health, approximately 43 million individuals experience mental health in a given year. You all, that is 1 in every 5 adults who experience a mental illness. However, nearly half of these individuals receive mental health services. So nearly 60% of individuals who are diagnosed with a mental health diagnosis do not receive services in a given year, according to NAMI. The overarching question is, what prevents these individuals from receiving mental health services? How come the BIPOC community have more difficulty accessing mental health services? And to make the mental health concern more clear in the BIPOC community, as I mentioned earlier, 43 million individuals experience a mental illness. Among the Black and African American community, that is 6.8 million of them. Among the Native and Indigenous community, that is over 23% of those individuals who experience a mental illness in a given year. The question is, what is happening? What is going on that prevent these individuals from accessing mental health services? As you can see, if you take a look at the picture on the right-hand side, those individuals could make up a different religion, income, gender, age, sexual orientation, gender identity. They can all make up different backgrounds. A health disparities is basically a particular type of health differences closely linked to those things I mentioned earlier, religion and gender, income and gender. With mental health disparities, the point is that they are complex. They are impacted by social and economic status. They are impacted by cultural backgrounds. When you hear that a certain population is more or less likely to experience a mental health concern or to experience a type of disparity, you have to ask yourself, what is the disparities that exist? For example, according to recent research, minorities are less likely to be covered by health insurance than their non-minority counterparts. Another example, minorities are more likely to drop out of treatment provided by various treatment providers. That's psychiatrists, that's social workers, that's counselors, those primary care doctors, specialty doctors. Minorities are more likely to drop out of services provided by various type of providers. Blacks are 3 times more likely to be provided or receive an antipsychotic medication than a non-minority counterpart. Because of mental health disparities, it makes it difficult for underserved communities to receive mental health care. And mental health professionals have to work hard to overcome disparities, especially as it relates to accessibility to mental health services, to programs and services that agencies and organizations offer in a community. When examining a mental health disparity, it is extremely important that we incorporate a framework that helps us to analyze the intersecting identities that I mentioned earlier. For example, cultural and social and economic status. When we use an intersectionality framework, it is a lens that helps us to see where power comes and goes. We have to look at intersecting identities when we examine mental health disparities in mental health care. Social determinants of health are conditions in which people are born, grow, live, and age. They include factors like education and access and quality of education. They include the healthcare sector and quality of healthcare services. They include the neighborhood and the environment in which you live. They also include your social background, your social network, and your social community, and also economic stability. The conditions in which we live explains in part why some Americans have access to services than others. Mental health disparities are associated with access and lack of insurance. Both geographic and provider level differences contribute to mental health disparities in mental health care. For example, let's look at the community, the neighborhood factor. Let's say individuals who live in urban communities may need access to mental health services. Fewer agencies may exist in that community that will allow individuals in that community to access mental health services. Let's say that these individuals may have to outsource to go elsewhere in order to receive services. And let's think about that neighborhood and environment aspect where a big social determinant of health is transportation, right? So these individuals may lack access to transportation in order to get to services. So we have to consider a lot of factors in order to figure out how can we meet the needs of BIPOC individuals. The environment in which we are born, live, play, work, and age impact our health and our overall health statuses. Some services exist in environments, whereas other services may not exist in environments. If you take a look at certain things in certain zip code area, you may have access to certain stores and produce compared to other zip codes. And for example, let's take St. Louis for example, where in St. Louis is divided by zip codes. And in certain zip codes, the stores look different when you go to like the Clayton area, which is the more affluent area. Whereas if you go to the county of St. Louis, and when you walk into like a grocery store, you may see fresh produce compared to when you walk into the similar grocery store in a different zip code. You walk into a whole bunch of junk food that is like really appealing maybe to that particular environment. So discrepancies exist, and we have to find ways to address them as it relates to these different sectors. To ensure that BIPOC have opportunities to achieve health equity in the following sectors: healthcare, education, employment, we have to do our part to reduce racial health disparities in mental health care. So now that we talked about social problem and we looked at mental health disparities, and we talked a little bit about that, and we looked at social determinants of health, it is important to ask ourselves the question: what is the unmet need that these individuals are experiencing? How can we put the missing piece to the puzzle? Racial and ethnic minorities tend to have significantly higher unmet need for mental health care than their non-minority counterparts. What is an unmet need? There are several definitions for unmet need in the literature. In this case, we are going to look at unmet need and first the need for mental health treatment, but not using any mental health service. So these individuals may have a mental health diagnosis and they may have access to services, but services may be insufficient. That means that it may not be effective for them. It may not address all of their mental health needs. Another definition is inadequate use of mental health service, right? So what that indicates is that these individuals still have mental health symptoms, but when they go to these services, symptoms still persist, and they services is not meeting their needs, so the services is inadequate for them. For BIPOC communities, we have to find ways to figure out how can we incorporate culture, or how can we incorporate their perspective into changing programs and services to help them meet their needs, to help them meet their mental health needs. Mental health affects individuals' well-being and overall health status because of unmet needs. So seeing that this is happening, and seeing that individuals have unmet needs, we must ask ourselves, what factors are impeding BIPOC access to mental health services, and what impact does this have on their overall health status? So let us take a closer look to examine unmet need in the US. This graph shows, like, it's a research study conducted in 2017 by Kim and colleagues. And basically, they found that geographic is an important but yet understudied area for disparities in mental health care. So this graph shows all of US in the 4 different regions of US for Black, Latino, and Asian compared to non-Hispanic white. So this graph shows that the national average for unmet need is around 67%. If you see on the graph, and let's hone in on the Midwest, since we are focusing on, this is the conference for the National Association Indiana chapter, let's focus on the Midwest, right? And let's hone in on that and figure out what's happening. If you take a look at that, what do you see? What is happening? Yes, that means that BIPOC fell behind the national average of unmet need in every single region of the US. What that means is that they had a higher rate of needed mental health services, but their need wasn't met. All in all, being a member of a particular racial and ethnic minority group increases the odds of having unmet need in mental health care compared to non-minority counterparts. BIPOC fell behind the national average in every single region of the US.
Let's take a moment to practice some mindfulness and truly understand the state of Indiana and BIPOC mental health care. I want you to visualize that you are cooking dinner and cutting up some vegetables. While cutting up the vegetables, you cut your hand. Your first response to the cut is to rinse it in some cold water and place a bandage on it. 24 hours later, the cut starts to bother you and you feel a small pain. So you remove the Band-Aid and you see that the cut has gotten worse and it appears to be infected. Now that the cut has gotten worse, you say, oh, I need to go to the doctor. So you go to the doctor to address the cut. Notice the difference between putting a Band-Aid and actually addressing the affected area. What does it look like then to put a Band-Aid on BIPOC mental health care in Indiana versus actually addressing the need and being proactive? This is a discussion to have in the spaces that you find yourself in. So one, is it creating more inpatient beds, or is it creating culturally relevant services beyond hospital stays? Two, is it creating more jobs or creating more employment opportunities that have mental health insurance benefits? And then three, is it creating more housing opportunities, or is it creating ways to engage the BIPOC constituents in services while they are in housing? There is a need for actually addressing the issue instead of putting Band-Aids on it, just like the cut needed to be addressed. So let's take a closer look at Indiana. According to the Office of Minority Health, 2019's Interagency State Council on Black and Minority Health final report, Indiana ranks 41 out of 51 in the country overall for overall health outcomes. Some examples of health outcomes are infant mortality rates, maternal mortality, substance misuse, and mental health. Today, we are specifically looking at mental health. The Office of Minority Health defined mental health access as access to insurance, access to treatment, quality and cost of insurance, and special education about mental health and workforce availability. Indiana ranks 44 out of 51 for adults with any mental health issue. About 25% of adults with mental health issues report they have unmet treatment needs. 24% of adults with mental health issues report they are unable to get the treatment they need. This ties back into the unmet needs Marcus referenced earlier. 9.5% of adults in Indiana with mental health issues are uninsured, and a little less than 54% of adults with mental health issues receive no treatment. Let's go a little bit deeper. This graph shows how many people are in Indiana divided by ethnicity. The two access rankings listed indicate how much access to mental health care exists within the state. All the ethnicities combined outside of Caucasian make up less than 50% of the population. However, they have less access to mental health services. So when we take a look at the barriers, the study identified that the barriers were, for all ethnicities, lack of insurance or inadequate insurance, lack of treatment providers, insufficient finances to cover costs, and a lack of available treatment options, such as inpatient, individual therapy, and intensive community services. Now, this was done pre-COVID, so you can imagine the effects that COVID has had. Also, we know that the BIPOC community has other barriers, such as mistrust, lack of representation, lack of knowledge, and a lack of culturally relevant services. So I want to share a story with you. I moved to Indiana in 2017, and representation matters to me, as I stated in the beginning. So my search for a Black female healthcare provider took about 2 years because I had to find one that actually took my insurance. I asked my doctor about Black therapists because, again, my motto is therapists need therapists, and you have to take care of your emotional and mental health for good self-care. And her response was, good luck finding one. We need you to hurry up and get fully licensed so that you can become one. Now, I work in the field and I have the knowledge, but imagine what it is like for those who don't.
I had a similar experience as Kendra, so let's dig deeper into healthcare and mental health on a broader spectrum as it relates to BIPOC individuals. As Marcus stated, a person's mental health is shaped by various social, economic, and physical environments, which are social determinants of health. In mental health care, health disparities do exist, especially among BIPOC individuals. Health disparities affect groups of people who have systematically experienced greater obstacles to health based on their racial and ethnic group. As you can see on the slide, some of the health disparities that research identifies are access to mental health care services, representation with providers of diverse backgrounds, ability to pay for inpatient and outpatient care, inadequate diagnosis due to lack of cultural competency and stigmas, and knowledge of mental health resources. Due to stigmas based on the BIPOC community and lack of culturally competent care, minorities are more likely to receive schizophrenia diagnoses and be prescribed antipsychotic medications more than their non-minority counterparts. There are also strategies that research identifies that need to be addressed beyond initial interaction in out and inpatient services. For example, minorities are less likely to receive family-based outpatient treatment, and family is an important cultural component to the BIPOC community. Also, minorities are more likely to be hospitalized, but less likely to receive outpatient services. And another area is that research shows is that the BIPOC community has emphasized the need for professionals to consider culture and religion. BIPOC individuals are less likely to receive mental health services than their white counterparts. Why? Because of historical misdiagnosis and treatment. Research examining disparities within medical and mental health settings indicates that racial and ethnic minorities have less access to mental health services, are less likely to utilize and receive necessary mental health care, receive poor quality of care, are less satisfied with professional mental health services, and have higher rates of dropout from these services when compared to whites. There is also research that focuses on how nonprofit board of directors have few people of color. This is also true of multiple nonprofit organizations that provide mental health services in Indiana. The implication is that the board of directors is on the outside looking in, but we need people on the outside who may look like the people on the inside. Poverty appears to be one consistent factor that influences health disparities, as research indicates that racial and ethnic minorities with severe mental illness who are socioeconomically disadvantaged are less likely than their white counterparts to receive medical and community-based mental health services. One way to reduce mental health disparity is to adapt and/or tailor best practices or identify new best practices to be more culturally relevant. Do you know of a specific disparity or barrier to minorities receiving healthcare?
So Monique, so that was a good question. And as you talk about healthcare, it is important to realize, like, when individuals need access to healthcare services, we must have to hone in on insurance, right? Typically, our insurance or lack thereof. We have to think about how does insurance coverage impact individual access to mental health services. For example, when I was working in the field, I worked in just various settings that served the BIPOC community. And majority or some of these individuals had Medicaid. And while Medicaid was limited in what they can offer and where they can get services from, it was hard for these individuals, or harder for these individuals, to really get access to specialized services like mental health care because of health coverage. So these individuals had to go to certain like clinics and only like certain like agencies in order to receive services. So let's think about like the barriers that even when people do have insurance, these people are BIPOC individuals are still underinsured because they don't have full insurance in order to help them to have access to provider availability. Let's talk about that, right? So these individuals typically are individuals who have Medicaid, typically have to go to community clinics. And in the community clinics, it's kind of like a one-size-fits-all model where it's like integrative care, which is a good model, where it's like a one-stop shop where these individuals have access to primary care, to women's health, to mental health services. However, within these populations or within these agencies, we have to look at the wait list for them to access these services, right? Because these community agencies are maybe the only agencies where these individuals get services at, it's typically a longer wait list for these individuals to access services. And when they are ready to access services, they may have already moved on. Also, insurance plays a huge factor in the quality of care, according to research that you get as well. Because like when these individuals go to these clinics, they may only get 15 minutes with service providers. I remember when I was working in the community, even an initial visit and a follow-up visit was both 15 minutes for these individuals. That's not enough time to really uncover some of the things that is going on in order to help these individuals have improved health outcomes, mental health outcomes. So it's important that we figure out ways in which we fight barriers on all levels that help these individuals to receive access to mental health services. No insurance is a disparity in healthcare. Having no form of insurance or being under insurance is one contributing factor that causes BIPOC to be left untreated worldwide. So these individuals are left with untreated symptoms of mental illness simply because of being under insurance or having no insurance at all in order for them to get the health care that they may need. And also, it's important that when these individuals do have insurance or lack of insurance, think about provider availability and representation. These individuals have certain agencies and populations in which they are able to get services from. And we have to realize that, or we have to make it aware that providers have to be culturally competent or take training in order to help these individuals with their unmet needs. It's important that we looked at insurance in order to figure out ways that these individuals can access mental health care while insurance is still a barrier. What does that look like? It may be advocating for more funding for your agency. It may be establishing programs and services that may meet the needs of these individuals in various ways that incorporate their culture. It's important that we look at insurance in the healthcare sector.
Another social determinant of health that we will address is employment. Our health is determined in part by access to social and economic opportunities. The lack of social and economic statuses affects BIPOC individuals in many ways, through poverty, food insecurity, and housing stability. Ways to improve social and economic opportunities for BIPOC individuals include creating access to economic and job opportunities, employment opportunities that offer insurance and/or EAP programs for mental health services, jobs not only offering insurance, but insurance that cover mental health services, and quality of mental health treatment that incorporates the needs of the BIPOC community. Even after BIPOC individuals receive mental health treatment, they show poor outcomes in occupational and social functioning compared to their white counterparts. Research shows that this is especially true of Black and Latinos. So that means even if a Black and Latino individual gets mental health treatment, they are still not performing as adequately in the employment and social environment compared to their white counterparts. I wonder why that is. Do you? Just hold that thought as we move forward. The next social determinant of health that we will focus on is housing. This map from 2013 shows Indiana's Black population and the areas across the state where they live. It's concentrated in the darker blue areas. Also, in 2011, Latinos had the highest increase in their population growth in Indiana. BIPOC individuals are highly concentrated in urban areas. There are 79 public housing agencies and 28 HUD-approved housing counseling agencies in Indiana. Out of these 28 agencies, 12 are concentrated within the 5 counties that have the highest population of Black individuals, and 12 agencies provide Spanish-speaking services. There are 34 community mental health centers in Indiana's urban communities, with 12 of them concentrated within 3 of the counties that have the highest population of Black individuals. But there is still a disconnect in addressing the underlying mental health concern for BIPOC individuals because there is only 1 mental health professional per 3,002 Black individuals. So that means only 1 in every 3,002 Black individuals are accessing mental health services. Mental illness carries a major economic burden from the people impacted and for the community. The importance of the relationship between neighborhood and health continues to be recognized with environment, place, zip code, and other areas in which you live, which are strong predictors of a person's health. Homelessness is a social determinant of health. Housing is a basic need. In an August 2020 article from Fox 59, it reported that African Americans make up 54% of the homeless population for the point-in-time count in Marion County. The executive director for the Coalition for Homelessness Intervention and Prevention stated that Black people are constantly being overrepresented in the homelessness population due to the systemic racism concerns with the criminal system. According to Mental Health America, criminal justice issues among individuals with mental health and substance use conditions is a growing problem. After the wide deinstitutionalization of state hospitals, jails and prisons have seen an increase in the number and percentage of individuals with mental health and substance use conditions who come through their doors. The deinstitutionalization movement of shutting down large treatment facilities for the mentally ill started in the 1960s. There was also a lack of community resources to address mental health issues, which resulted in people going to prisons and jails instead.
So let's break down the racial disparities of who is represented in the criminal legal system. The process of being incarcerated first starts with arrest in the community. There are racial disparities among people of color being overly represented in the criminal system at larger rates. In 2011, 40% of people incarcerated were Black, even though they made up 13.2% of the US population. 20% of incarcerated were Hispanics, even though they made up 17.1% of the US population. The Department of Justice reports that Black people experience force by police 2.5 times more frequently per police contact than white people do. In 2015, 27% of police shootings involved a mental health crisis. And from 2015 to 2020, 22% of all the people shot by police had known mental health conditions. According to Human Rights Watch, law enforcement participation in the enforcement of immigration laws, generally directed at non-white people, has served to criminalize segments of Black and Latino populations. Arrest and police violence, from low-level harassment to lethal force, disproportionately impact Black, Native Americans, and Latino people. This is also seen with Black, Native American, and Latino youth. Native American youth are incarcerated at rates 3 times greater than white youth. Black youth are incarcerated at 4 times the rate of white youth, while rates of drug use are mostly similar across races. Black youth are 2.5 times more likely to face arrest for drug possession as white youth. Black youth are 3 times as likely to be arrested for loitering or curfew violations than their white counterparts. There is also historic systematic racial disparities in case processing and sentencing. The American Psychological Association reported that Blacks were more likely to be incarcerated before trial, to fare worse in plea agreements that might otherwise have kept them out of prison, to receive the death penalty, and to be arrested and charged with drug crimes, which carry mandatory sentences. The American Psychological Association also found that people of color are more likely to suffer disparities in mental health treatment in general, which results in being more likely ushered into the criminal system versus the mental health system. This racially impacts the criminal system and the institution of urban poverty. Even though there are more white individuals incarcerated in Indiana, Black individuals make up 10% of the population in Indiana, but in the Indiana legal system, they make up 34% of those incarcerated. So looking at mental health and substance use as a growing issue in the criminal legal system, aside from the deinstitutionalization of state hospitals, other factors were happening between the 1960s and 1980s, which was a rise in crime. Crack cocaine and other drugs resulted in huge increases in drug penalties. According to the American Psychological Association, a move to mandatory minimum sentences, the implementation of tough on-crime policies like 3 strikes, and policies to ensure prisoners served at least 85% of their sentences, drug penalties and harsh sentencing measures increase the state and federal prison population. Dependence on alcohol and other drugs is common among prisoners. The Bureau of Justice Statistics reports that state prisoners with mental health problems were twice as likely to have been homeless, twice as likely to have lived in a foster home, an agency, or institution while growing up. Significantly more likely to have reported being physically or sexually abused in the past, to have had family members who had substance abuse problems, and to have a family member who had been incarcerated in the past. About 42% of the state inmates had both a mental health problem and a substance use dependence or abuse. Many people with mental health issues, particularly those who are poor, homeless, or struggling with substance abuse, receive imprisonment, even for low-level nonviolent offenses instead of mental health treatment.
As we look at more into the criminal legal system and just the facility of it, According to a 2006 Human Rights Watch article, new federal statistics from the Bureau of Justice Statistics reveal that the number of mentally ill inmates in U.S. prisons and jails has quadrupled over the past 6 years. More than half of all prisons and state inmates report mental health problems, including symptoms of major depression, mania, and psychotic disorders. Those incarcerated in prisons and jails who suffer from mental health problems were reported to estimate 283,000 in 1998 to grow to 1.25 million in 2006. At that point, the rate of reported mental health disorders in the state prison population was 5 times greater, at 56.2%, than in the general adult population at 11%. Now let's look at more recent numbers. In 2011, the American Psychological Association reported that 64% of jail inmates, 54% of state prisoners, and 45% of federal prisoners reported mental health concerns, with substance use co-occurring most of the time. In August 2021, Prison Policy Initiative reported that 44% of jail inmates and 37% of state and federal prisoners have diagnosed mental illness. This drop in numbers can be due to an emphasis put on decreasing mass incarceration by the Obama administration, but at the same time, the administration increased mass deportation, which is another area of mental health. Current statistics of today from Prison Policy Initiative report that there are 1 in 4 people in jails experiencing serious psychological distress, and 66% of people in federal prisons report not receiving any mental health care while incarcerated. 27% of people jailed 3 or more times within a year report having a moderate or serious mental illness. Being incarcerated definitely exacerbates mental health issues because it is a specific type of trauma, just like other traumatic events. Mental health issues are increased even more when you couple solitary confinement and little or no programming or social interaction. Studies show that lasting mental health effects of incarceration includes post-traumatic stress, anxiety, impaired decision-making, depression, and hallucinations. The American Psychological Association studies have found that overcrowded prisons decrease psychological well-being and increase risk of suicide. The APA also identifies most people in our jail population who are suffering from treatable illnesses who are not getting treated and then end up caught up in the criminal system as opposed to the mental health system. About 10 to 25% of US prisoners suffer from serious mental illness, such as a major affective disorder or schizophrenia, as compared to about 5% for serious mental illness in the US general population. To highlight another disparity, the American Psychological Association identified that women prisoners have a higher rate of mental health problems than men, at 73% of all women in state prisons compared to 55% of all men in state prisons. The American Psychological Association identifies that the transition to care outside of prisons is not adequate because of historically not having an effective pass-off to the services provided in the community. Oftentimes, mental health services and other specific medical services are seen as areas where costs can be cut. Historically, incarcerated individuals have had to pay a $2 to $5 copay for healthcare services, which is an obstacle to care when they're in prison. In the last few years, some states have been moving towards providing free healthcare visits to those individuals. Mental Health America is dedicated to addressing the many issues of states, communities, and criminal justice systems in order to reduce the number of individuals who must suffer by rotating in and out of jails and prisons. If prisons are growing to be the nation's primary mental health facilities, what do they need to be equipped to handle this concern. There needs to be continued reform to address societal problems, investment in communities to advance public safety and equal rights, and independent accountability and oversight mechanisms that advance justice as reported by Human Rights Watch. But I ask you, what is justice? In talking about public safety, we also have to address community trauma. As awareness of impact of trauma goes, it is important to understand each individual's perspective of what is traumatic to them as they visit these healthcare systems. When you think about community trauma, you cannot discount how race plays a role in society in regards to someone's mental health. Since the shooting of Michael Brown in Ferguson, Missouri in 2014, the Black Lives Matter movement has been an initiative that is a norm to not only Black and Brown youth in America, but to allies in America and all over the world. The Charleston church shooting in June 2015 was a mass shooting in Charleston, South Carolina, where 9 African Americans were killed by a white man. This was an event that shook not only the Black community, but the entire American community as well. This killing was racially motivated, and the irony of the situation is that when he was arrested, it was a very peaceful arrest in contrast to some of the minority groups listed above that Kendra kind of referenced when she talked about Black and Brown and BIPOC individuals in the criminal legal system. This makes me think about the church bombings during the Civil Rights Movement, and especially the 16th Street Baptist Church bombing in 1963 that killed 4 little girls. In terms of community trauma effects on the groups of people's mental health, you have to acknowledge that church is considered a safe space, not only in the African American community, but also in various other communities. According to the Post and Courier, the incident in Charleston sparked an international conversation about safety in sanctuaries, employing off-duty law enforcement for Sunday morning worship and nighttime Bible studies, along with updating security systems and active shooter training to protect themselves in places of worship. Community trauma is also prevalent in other racial minority groups as well. We can also look at the violence and discrimination toward the Arabic community, or anyone who is perceived to be from that community based on their outward appearance, specifically right after 9/11 in 2001. Let's look a bit more recent. When it was identified that the coronavirus originated in Asia during the current COVID-19 pandemic that we're in, the Asian hate incidents were on the rise. The Stop Asian American Pacific Islander Hate.org identified that Asian Americans who have experienced racism are more stressed by anti-Asian hate than the pandemic itself. 1 in 5 Asian Americans who have experienced racism display racial trauma, the psychological and emotional harm caused by the racism. After reporting, Asian Americans who have experienced racism have lower race-based traumatic stress. Asian Americans who have experienced racism have heightened symptoms of depression, anxiety, stress, and physical symptoms. And those who experience their experience of racism during COVID-19 is found to be more strongly associated with post-traumatic stress disorder symptoms. In the January 2021 Martin Luther King Jr. Oratory Scholarship Competition with high school juniors and seniors in Pennsylvania from diverse racial backgrounds, they had to identify what effects the pandemic has had on them. Statements were identified as, with everything on hold during the pandemic, racism was not. And resiliency is daunting. It would be most beneficial for us to recognize that with the prevalence of social media and technology, youth are being exposed to trauma that is happening not only in their communities, but in other communities to people who may or may not look like them. What effect does this have on the person's psyche and their mental health? And what message is being sent as a broader society about racial minority groups? In your work at the micro, meso, and macro levels, you want to ask yourself, what is the prevalence of trauma in the community that you are serving? Systems and we as people can perpetuate the community trauma that a group of people experience. This can come from getting a bad vibe from us as professionals, getting turned around or turned away from the services that we provide, or simply feeling like we as professionals see them as the client as inadequate. Trauma is whatever is traumatic for that particular individual. And remember, trauma is a highly stressful, toxic event that has lasting effects. Being a BIPOC person in America can be a traumatic experience. In August 2021, Human Rights Watch identified that the United Nations Human Rights Council recently adopted a UN resolution to create an independent mechanism made up of 3 experts to investigate the root causes of systemic racism and police violence. The 3 independent experts were responsible for examining systemic racism as well as government responses to peaceful anti-racism protests, discriminatory policing, and other human rights violations against Africans and people of African descent around the globe. Pressure from a number of Western countries, particularly the United Kingdom and European Union, successfully removed the language that mentions the need to investigate systemic racism in law enforcement in the US. But the resolution did retain language around the May 2020 killing of George Floyd, which sparked global protest, and language that focused on racial discriminatory US human rights violations.
Okay, so Monique, so that was a lot to process. We talked about the healthcare system, we talked about employment, we talked about the criminal legal system, and we also talked about community trauma. So when talking about all of these things, we have to look at oppression, which is basically social inequality woven throughout social institutions, as well as embedded in individuals' consciousness. So these are systems of institutional and systematic discrimination, personal biases, and social prejudices against social groups, typically groups who are marginalized. So as you think about everything that we talk about and our experience in the field, what is your understanding of systems of oppression and their influence, Monique?
I believe there are systems of oppression in all the isms. There are multiple ways to be a part of a minority group, such as race, sex, religion, gender identity, sexual orientation, language, age, ableism, mental and cognitive abilities, and socioeconomic statuses. We have to recognize what role we play individually to others and to society as a whole. Understanding when we fall within the dominant group or the subordinate group of those isms, and also understanding that groups of people are not just one-sided based on stereotypes. Kendra, do you have an idea of what your understanding of systems of oppression and how they influence?
Yeah, so one thing that comes to mind when I think about system of oppression, when I think about it at like an individual level, microaggressions come to mind, and how we all perpetuate them, and how those are the microaggressions are the beginning of our stereotypes and biases. And so, for example, a microaggression might be, because someone, you may think in your mind, because a black woman has long hair, that it's not her hair. And you may ask the question like, oh, is that your hair? Or you may say, oh, are you mixed with something? So that is a microaggression, because you already have an assumption in your mind. And then you are then continuing like biases and perpetuating stereotypes. And then, but recognizing that we are not all just one-sided, and that we all do this. Every race, every person, different backgrounds. We all have those microaggressions, and that we need to be self-aware of how we're contributing to a system of oppression. And then when I think about on a macro level, just in my experiences, the clients that I've worked with, they may enter the system, a system of oppression, just by being in the criminal legal system, right? They may enter the criminal legal system like we talked about, but then now this affects them. Now they are looked at a certain way, and it affects the way they can even access housing, like you mentioned, or it affects the way they can access employment. They may not even be able to get employment. And so then all of these things, this one access point into the criminal legal system, which is can be a system of oppression, as we highlighted, has now created multiple systems of oppression that intersect.
So we have to consider our work from a social justice lens. When we talking about the things that we are talking about, we have to look at social justice and figure out what is it? Social justice is fighting for populations who are marginalized to have fair and equal treatment and opportunities. So let us all just take a moment to take a look at this picture. Let's say that your agency or organization receive free tickets for your clients to go to a baseball game. This is the game of the year where the Cubs and the Cardinals are playing. So your agency distribute the tickets to clients. And let us take the moment. So everybody had access to go to the game. So let us take a moment to look at the picture on the left. Equality. If you look at that picture, think about what is happening. What is going on with equality? Exactly. The goal is that everyone has the same thing to be successful. Everyone was provided a ticket to go to the game. But what doesn't equality do? As you take a look at the picture on the left, equality doesn't promote fairness, right? While everyone has equal access to something, it doesn't promote fairness. What is happening with equality? Your clients receive tickets to go to the game, but did everyone enjoy the game? Was everyone able to see the Cubs get the home run? No, exactly. So let us transition to the picture on the right, equity. Just take a moment to figure out what is happening and what is going on. Exactly. As you can see, equity is understanding where people are and provide them with the resources that they need to be successful. Equity, as you can see, is a level playing field. So what happened? We realized that your agency or organization had tickets for every client to go to the game. But guess what? We talked about social determinants of health earlier, and some clients may live in a neighborhood where they don't have access to even have transportation to get to the game, right? So just think about equity right here in this context. If you look at the picture, now the person is able to see the Cubs get the home run because what happened? We realize where people are and we met them where they are and we provide them with the resources that they need to be successful. Equality doesn't get the problem solved. We have to find ways to be equitable. We have to incorporate equity into our programs and services so that everyone can be able to enjoy the game and put their hands in the air when the Cubs get the home run. It is important to recognize that inequalities in housing, employment, mental health services produce differences in health status and health determinants that are considered unfair and avoidable. Equality doesn't mean equity.
I want to highlight again that equality is not equity. Our goal here today is to focus on bringing equity to the mental health system for BIPOC individuals. Hopefully, we can remove barriers to anyone who is disadvantaged when being able to access services. According to Human Rights Watch, harms resulting from U.S. policies at the federal, state, and local levels continue to disproportionately impact Black, Indigenous, Latinx, and low-income communities, posing grave dangers to their social and economic well-being. At the macro level, we need to confront the U.S. history of systemic racial discrimination and support laws and policies that protect the rights of all people and address racial disparities in health, education, housing, employment, and the criminal legal system. It is imperative for agencies and organizations to think about ways to truly be inclusive in their ideas, actions, delivery of services, and advocacy. Liberation is the act of setting someone free from oppression. This means incorporating an intersectionality lens and framework. This will expand, modify, and shape your cultural lens to effectively transition from cultural competence to exhibiting cultural humility and engage with others impacted by oppression and/or marginalization. Here is a video to highlight cultural humility.
One word to describe cultural humility for me is love, actually.
If I had to encapsulate cultural humility or the whole concepts of cultural humility, it doesn't do it justice, but the word that I think of it is essence.
Escuchar.
Being.
You.
Opening.
Receive. Compassion.
Love.
The principles of cultural humility offer one more framework to contribute to what has got to be our ultimate goal, yes? Our ultimate goal is that there will be a sense of equity, a sense of equality, and a kind of respect that we are driving forward.
Cultural humility is a multi-dimensional concept, and certainly Melanie Tervalon and I conceptualized 3 dimensions.
The first is lifelong learning and critical self-reflection. And in that critical self-reflection, it is the understanding of how each of us, every single one of us, is a complicated, multidimensional human being. Each of us comes with our own histories and stories, our heritage, our point of view. You're looking at me now. I am very fair-skinned. When I was a little girl, my hair was blonde. My eyes are blue. People often tried to call me anything but African American. I have a history. My identity is rooted in that history. My parents gave me the knowledge of my own social identity, and my own experience in life has created that. I get to say who I am.
The second tenet, after self-reflection and ongoing lifelong learning and development, is this notion that we must mitigate the power imbalances, to recognize and mitigate the power imbalances that are inherent often in our clinician patient or clinician client or service provider community dynamics.
And then finally, the piece that I would offer that Jan and I feel people often either don't read or don't like, which is, and the institution has to model these principles as well.
So what is being done in Indiana? Organizations like NAMI, the National Alliance on Mental Health and Mental Illness, and the Indiana Department of Health's Office of Minority Health support the following: establishing a unified data collection system, preparing evidence-based documentation of racial and ethnic health disparities in Indiana, develop a plan of interventional strategies designed to eliminate racial and ethnic health disparities in Indiana, have local partnerships that can provide access to affordable housing, suitable employment, and treatment, and equity reimbursement rates for mental health providers. So some state and local organizations support and understand the need for change. Mental health is important to social determinants of health. There is some awareness about mental health challenges, but what are next steps? So an example is, I found an article from the News and Tribune. It's called New Mental Health Treatment Programs for Inmates in Hoosier Jails. This program describes the Indiana Family and Social Service Administration's Division of Mental Health and Addiction, announcing a series of pilot programs designed to increase access to mental health care for inmates in Indiana County jails. The pilot is being launched for the 3 parts of the program in Marion and I'm sorry if I mess up this county, Vanderbilt counties. And so the one key thing to remember is they will focus on individuals found unable to stand trial who are awaiting placement in the state and psychiatric hospital network. DMHA will partner with various providers to provide services in the jails, in the community, and then in private inpatient settings. So the jail-based restoration pilot is being launched in Marion and Vanderbilt counties in partnership with community mental health centers like Adult and Child and Southwestern Behavioral Healthcare Incorporated. They will provide services directly to jail inmates with a goal of restoring competency and resolving the criminal case more quickly. And then the community-based restoration pilot will happen in Marion County in partnership with Adult and Child. It is geared toward providing competency restoration to individuals whom a court decides are safe to return to the community. And then the inpatient pilot program is called Project Create. CREATE stands for COVID-related emergency access to therapeutic environments. The program will transition county jail inmates throughout Indiana to partnering inpatient psychiatric providers. And so one thing to highlight here and to know, it is very important as we just, as providers and then the jail system, they understand that the stakeholders, they are key and they are stakeholders, and they need training in cultural humility, just like the video reference. Because what we know is there is a disproportionate amount of BIPOC community in the criminal legal system, as Monique and I stated earlier. Now we're going to watch a video that shows a positive change and resource coming to Indiana.
Evaluate Crisis Center, how may I help you?
Just like 911.
There's help there.
And more help is on the way.
Our job is to talk them through the crisis, and then with 988, there will be so much more to take it from that step into other steps that will allow them to heal.
Starting in July of 2022, 988 will be the number you'll call for mental health help. Indiana lawmakers have already set aside funds for infrastructure, and they're thinking about future ways to fund it.
The beauty of the 988 system is that once it's in place, if there's a similar fee structure to what's used to fund the 911 system, that program alone can bring in approximately $50 million a year.
In the meantime, call centers like A Better Way Services and Mental Health America are addressing Hoosiers' needs now.
We saw, I would say, about a 45% increase in call volume.
Across the nation, calls to crisis centers have increased dramatically.
Duke Energy is helping them keep up with the high call volume with a $100,000 grant.
They are on the front lines making a difference for so many people.
Both call centers are hiring right now and looking for more volunteers. They hope lawmakers continue to prioritize mental health and increase funding for 988 in the future.
We should be able to take advantage of the progress that we've made and build on that. And hopefully create a system that serves all people in the state of Indiana better than we have in the past.
Kayla Sullivan, CBS 4 News.
Keep in mind you can still call 211 to find mental health resources. We also have a list of other call centers on our website, cbs4indy.com.
These are examples of addressing the need and being proactive. One thing to highlight is the information needing to be disseminated. The video had 20 views in June when we found it, and at the end of August, it only had 30 views. And so it's important that the people in the community, especially the BIPOC community, know about this resource. One additional step is also looking at other programs across the country that have promising models. For example, in Eugene, Oregon, there's a program called Crisis Assistance Helping Out on the Streets, CAHOOTS. They deploy medics and mental health professionals instead of police to situations involving people experiencing crises or with other mental health needs. Rather than prioritize obedience and control, they prioritize problem solving and calming to seek safety for everyone involved. CAHOOT workers, they respond to calls, they make basic medical evaluations and offer services if a person voluntarily accepts them. They also, so it's to note, they respond to approximately 20% of the 911 calls in Eugene, Oregon. And they actually, it seems like they're being underused, but the program has a promising model as long as mental health professionals respect the autonomy and rights of the people they serve and do not recreate the same coercive approaches used by many police. So the following are recommendations and critical suggestions for best course of action to address the needs of the BIPOC community. So the first one, evaluate healthcare systems to ensure they are culturally relevant to meet the needs of the BIPOC community. There is a need to move from just cultural competence practices to cultural humility. This means placing cultural humility at the center of our cultural competence practices. It is the willingness to go beyond simply understanding and appreciating differences and diversity that exist among human beings. It is the intentional willingness to practice mindfulness regarding culture. This also means that you must take steps to create self-awareness of your own biases, humble yourself to recognize your strengths and limitations in practicing cultural competence and sensitivity, and an ability to engage others in open dialogue to ensure that you are identifying the institutional and individual cultural norms that create power imbalances and barriers for your clients. 2, conduct annual data collection and dissemination of the information to inform effective program practice. The data is not easily accessible for organizations and providers to inform their practices. In speaking with someone that worked for a state agency, the information was not easily accessible to them and they worked there. 3, promote collaboration among local agencies to create a network of resources. You are the experts in what your agency is providing. It is beneficial to collaborate to connect the clients to resources. And then 4, more BIPOC mental health professionals, and training for non-BIPOC professionals. This means improving the scope of training for staff and having representation in professionals serving the BIPOC community. One area that would affect this would be having more faculty of color. And two pros to this are having worldviews and representation from people of color, and then BIPOC professionals seeing themselves in the collegiate field. And while you do not have to be a person of color to teach a person of color, remember, experience does matter. 5, explore how programs, practices, and policies affect the health of BIPOC. This means looking at how programs, services, and interventions are evaluated, and then figure out ways to identify and develop culturally based mental health treatment to meet the needs of the BIPOC community. Number 6, maximize opportunities for collaboration among federal, state, local level partners to achieve mental health parity. Federal, state, and local partners have a stake in making positive change, so collaboration is necessary for favorable results. And number 7, keeping individuals engaged in services beyond the initial interaction in outpatient and inpatient settings. This looks like improving the infrastructure of mental health services and engaging the BIPOC community beyond the initial interaction, which sometimes can be negative, into the mental health system. This also means eliminating stigma and biases for correct diagnosis and getting internal supports like family involved in the process. And lastly, number 8, complete a needs assessment to incorporate perspectives of the BIPOC community. While you may be experts of what your agency provides, the BIPOC community is the expert in what the needs are. Effective programming and treatment start with the perspective of the client and what they feel their needs are. Implications are designed to determine the effects of recommendation on policy, practice, and research. By incorporating the recommendations, we will have the opportunity to reduce stigma, increase trust in the BIPOC community for the healthcare system, understand the role of culture and religion, and fund best practices. It is important that we address and begin to meet the needs of the BIPOC community in Indiana for optimal health outcomes. Lastly, I leave you with this quote by Jane Goodall. What you do makes a difference, and you have to decide what kind of difference you want to make.
This presentation should have provided you with some guidance to move from disparity to parity. In 2016, SAMHSA outlines this process as starting with examining the mental health disparities, move towards culturally competent approaches to reduce mental health disparities, which in this presentation, we identified replacing cultural competence with cultural humility, and then begin to evaluate if there are any reduction to the mental health disparity you are addressing to ensure a level playing field. Thank you for joining us. If you would like to continue this conversation and explore the idea of a cultural broker, having someone to bridge the information of different cultural backgrounds for the purpose of producing change, our contact information is listed below.
CareSource is a nonprofit multi-state health plan recognized as a national leader in managed care. Founded in 1989, CareSource administers one of the nation's largest Medicaid managed care plans and offers a lifetime of access to care through health insurance, including Medicaid, Health Insurance Marketplace, Medicare Advantage, and dual-eligible programs. At CareSource, we work to bridge gaps to better care by improving health equity, health outcomes, and health literacy in communities where CareSource members reside. We want to be a partner in creating vibrant communities where people want to live, work, and play, ultimately driving economic growth and helping individuals lead healthy lives. CareSource serves more than 2 million members, supported by a workforce of more than 4,000 across 6 states. CareSource, we're building partnerships.